for you guys since I knew you worked last night and everything. But basically what I'm doing for you today is an update because we're changing a lot of processes within the hospital with our stroke care, specifically for when a patient has a stroke in the hospital. So that's the biggest thing that we're gonna change. So currently, just to give you the back process, currently our process in the hospital is that when a patient comes in with or with something else, let's say they're here for a toe amputation or something, and then they're here in the hospital and they have a stroke. Currently the process is if they need TPA, they go back to the emergency room. And it's not a great process, right? We should be able to care for them in the ICU. We've had some hiccups over the years. Our previous ICU medical director really didn't want us to give TPA in the ICU, but that process is going to change, and now we have a second telestroke machine, so I'll explain that a little bit, but that's the reason for today. The other big change is that we are going to be calling a code stroke overhead. I know that do you guys go to Code Blues? Actually, I was thinking about this morning. You do?
Don't we do, right?
We do.
On the floor?
It depends on what's going on with the unit, but sometimes we go, a lot of the time we go.
Okay. Is that I don't know why my brain was turning this morning and I was like, oh, do they go to the Code Blues already? Because we're still in the works with the code stroke and how it's going to function. I don't anticipate the APN is going to all of the code strokes because it would be, I don't know if it's going to be a lot or not. We'll have to see once we start going, which is part of why we need to change it because right now we just call a rapid response overhead and I don't know if it's a stroke. CAT scan doesn't know if it's a stroke. The lab, nobody is on board with suspected stroke signs until we get there and discover what's going on with the patient. So right now we do have a code stroke intervention. That's what we call it. We are going to be changing the name to code Neuro intervention. Right now, code stroke intervention is when we activate our team to come in and perform the thrombectomy. So a patient has a large vessel occlusion and we have to pull that clot out. We call code stroke intervention, which I just mentioned is going to be changed to code Neuro intervention, just to hopefully get rid of the confusion of accidentally calling in the team. But so now code strokes are going to be called overhead, and the same team is going to respond. One of the ICU nurses, the charge nurse from ICU, hospitalist group, they are going to go down to CAT scan with the patient, and that is where the teledoc machine is going to be housed. We figured that there's one thing in common with all stroke patients, they all end up getting a head CT at some point. So the machine will be down there, and that's where the telestroke consult will take place. Obviously, you're not going to be there for the telestroke consult. That will be the hospitalist, the ICU charge nurse will take care of that. But I am going to go through the process with you and teach you everything that I taught the APNs because I want you to be able to do the system yourself too. In the event that we need to call back the telestroke doc, something's going on with the patient, they just got TPA, we're not sure what to do, so that you're able to call them back. So that's kind of the gist of that. So when we're talking about TPA, not a whole lot has changed since we've all been in nursing school. We still only have a 4.5 hour window to give TPA. So of course we're going to be trying to figure out when the last known well is. And you've all seen the CT triple scan that we do for our stroke patients now. So when a code stroke is called overhead, just to paint the scenario of a patient coming through the hospital, let's say there's a patient on 3 Chadwick, code stroke is called overhead, our normal rapid response team would go. And then when we get to CAT scan, while the patient's in CAT scan, we're gonna start to activate the telestroke machine. So this is not completely set up yet. I'm planning on doing a mock and recording it so that everybody has something. But basically I'm gonna print the phone number on the front of this machine. So again, this will be in the CAT scan waiting area downstairs. Everyone knows where I'm referring to. And there will be a phone number on here. The process for the telestroke is that we have Overlook Medical Center's neurologists cover our telestroke machine. So that's who is answering. Well, there's really 2 groups, but I'll explain that in a minute. But the number will be there, and when we call the number, it will be Overlook Transfer Center. and we just need to tell them it's holy name, we have a stroke patient, and they connect us, and we hang up, and the doc will pop up on the screen. It's actually extremely simple. When we were first doing it with the emergency department, I was like a little confused about how it would function, but they're really good. They come up on the screen within 5 minutes. Like they're very accurate about it. I anticipate that if we call when the patient gets on the CAT scanner, they'll be on here before the patient's even out of the CT. So you call that number, and then also at the same time, we have I pulled it out. So there's a website that we have to put in the patient information. You guys won't be responsible for the, actually I'll just give it to you guys. I have one for you as well.
Thank you.
So on the left here, this stroke respond is a portal in which we go in. Let me see if I can share quickly how to get into that. I feel like I'm jumping around a little bit, but I'm just trying to go through the process with you. So when you go on WebHIS, these websites are in the approved websites. Everybody knows how to find the approved websites. You know what I'm talking about? So if you go over here to your approved websites, Stroke Respond is one of them if you go down to S. And I don't know if you guys know, but these little stars are favorites. You can click on these and make it one of your favorites so that whenever you're logging in, this is what you will see and it'll be on your main dashboard. So I recommend doing that. But so you go into Stroke Respond, and in here, the ICU nurse, the charge nurse, will be putting in the patient's information. I did make you guys accounts because I want you to be able to log in and print. So what else did I want to go through with you? All right, so then I did just want to go through the actual delivery of TPA. We're building an order set. Right now, the TPA orders are paper, which I plan on leaving actually on paper because I think this is like one of those critical drugs that it's helpful to like look at. We have some reminders on here about blood pressure parameters as well as a reminder, to check the POC-INR and different things like that. Obviously, the emergency department has been giving TPA for a lot of years. So if you ever have any questions, I did ask the charge nurses to serve as resources for you guys. I think that they'll be helpful if you ever have any questions. You may be a little bit familiar with the forms from when a patient gets TPA in the emergency room and comes up to your unit. You've seen these forms before. However, I know that you've never used them or filled them out. I plan on having the IT peeps put an order in WebHIS that says Alteplase so that when you put in Alteplase in the MAR, like medication order, it'll print these sheets for us to fill out. What I would like to see happen, however, is because you're not going to be there for this consultation, I'm going to ask the hospitalist to put that in. I already have asked them. They are going to put it in. They have no choice, really, in the matter. But if the teleneurologist is recommending TPA, they will put that order in, and then the nursing staff will fill this out with the doc or with you after we figure out the calculation. So I did want to just go through it with you guys on how to mix the TPA in case you're the second nurse that's a witness. And this is just like a little handout thing about TPA.
Thank you.
You're welcome. So this is the dosing card. I think you'll find that the actual mixing of TPA is very easy. This is the dosing card. So the first couple of things that we need before we give TPA is obviously a negative head CT, right? We want to make sure there's no bleeding before we ever give TPA. And then we also need to go through the exclusion and inclusion criteria for the patient. So the major things with the exclusions, don't feel like you need to memorize this. I should have printed this. I didn't give you a copy of this. I plan on laminating it and putting it on the machine as well so that we always have it handy. But the major exclusions, of course, are recent major surgery. When we say surgery, we're talking about a non-compressible site. The other things are if the patient's on anticoagulation, of course. So the most common exclusion that we're seeing nowadays is the Eliquis and Xarelto patients, right? If they've taken a dose within the last 48 hours, they're excluded from TPA. So that would be another big exclusion that we see. So this top section is all of the absolute exclusions. There's a middle section that reminds you the blood pressure needs to be less than 185/110 before we give the TPA. We don't want to bottom them out, of course, right? We're still allowing for permissive hypertension, but we want to get it to a level where the bleeding risk isn't as significant. So 185/110 is that goal. We want to make sure they have a normal blood glucose and a normal INR before we give. This bottom section, these precautions and considerations, they're not absolute exclusions. They mean we might want to have a little more discussion with the family before we give it. The most common one is the first one, the patient's on Coumadin, but their INR is subtherapeutic. Maybe they were off of it for a few days for surgery or something, and now they're having a stroke, and we're thinking about giving TPA. So they still could potentially get TPA even though they were on Coumadin. So some of those things. So I just wanted to briefly go through those with you. We also need, like I said, an INR. Part of the code stroke order set that the hospitalist will be ordering is going to be a POC INR. So the lab will come and draw a POC INR. So negative head CT, we need an accurate weight, and we need the INR before we give. For the case of patients who are inpatient, we will normally have lab values already from that day, or at least from the day before, so we don't have to worry as much about the labs. In the emergency room, they usually bypass the labs for everything except the INR. We need that INR before we give. So now, again, just painting the scenario, the telestroke doc tells us we're going to give TPA. The patient now goes up to the ICU. I've encouraged the ICU charge nurse to bring the machine with them. Even though that consultation is done, I think while the patient is getting TPA in the unit, it will be helpful to have the machine there just in case you're questioning or second guessing anything and you want a neurologist in front of you again. We pay for this for the year. It's not like every time we call them, we pay them, so don't feel hesitant to use it. I would like you guys to use it as much as you need. And I know it's kind of been hard throughout the years to not have a neurologist overnight that responds quickly. Sometimes you have specific questions, so this will be helpful in that scenario as well. So we have 2 TPA kits, or really 3 TPA kits in the hospital. It's a green tackle box. 2 of them are in the emergency room and 1 is in the pharmacy. The ICU will be using the one from the pharmacy. So if we get the go-ahead to give the TPA, someone will have to grab the TPA kit from the pharmacy. And in the TPA kit is really everything that you need. You have your TPA, you have the tubing, you have the dosing cards, all of this. So if you can just take a peek at your dosing card. A couple of things I want to mention to you. You can see that the pounds go by every 2 pounds. So if you have a patient that's, say, 221 pounds, so go to 221 pounds, you're going to round down to 220. So 220 is actually the max dose, 90 milligrams is actually the max dose. So any patient that's over 220 pounds is just going to get that 90 milligram dose. So that's why it's very important to use the card and not to try to do the math from your brain. Because the card, you can never overdose the patient if you're using the card. Again, all the ICU nurses, I went through this very thoroughly with them, and I plan they will get an annual competency on this. So they're really going to be the ones mixing. I just want to make sure you guys had some basic knowledge on this. So that's how you do the dosing. I'm just going to pull it up, even though you guys have it in front of you. The Alteplase orders, the second page of that Alteplase orders, looks exactly like this card. So when we're filling this out, you put the patient's weight here. You can see these 5 boxes correlate with the 5 boxes on your dosing card. So we've tried to make it as easy as possible. It's just an exact copy, the weight, the dose, the discard, the bolus, etc. So the first thing that we're going to do is we're going to calculate the dose, and we're gonna start filling this out. And then we need to actually mix the TPA. So in the kit, again, you have 100 milligrams in 100 mLs of sterile water. Very easy, 1-to-1 ratio, and they give you this large bore transfer device. So we have a very corny saying, but because the bore is so big, you want to pierce the powder first. Because if you pierce the powder, nothing's coming out. But if you pierce the sterile water and you invert it, you're going to lose some of that sterile water. So we say clouds over water. Clouds over water, make it rain. Just something to remind you. It is common sense, but in these high stress moments, all of our thoughts go out the window. So clouds over water, make it rain. All of the sterile water is going to go in the powder. And now you have a 1-to-1 ratio, 100 milligrams and 100 mLs of TPA. And then we just use the dosing card, and it's super simple from here. So the first thing that we're gonna pull out is our discard quantity. All of the syringes are in the box as well. There's a bigger Toomey style looking syringe. So you can use that to pull the discards because the discard is usually more. So let's say patient is 124 pounds. Our total dose is 50.8. Our discard quantity is 49.2. So the first thing that I'm going to do out of this 1-to-1 ratio, 100 milligrams and 100 ml, is I'm going to pull out that 49.2 and get rid of it. Toss it, drain it, whatever you're going to do with it, but we're going to get rid of that TPA. Then we have a 5.1 bolus dose. Any nurses can give the bolus dose, but if you guys are around, I'd like you to give the bolus. It gets pushed over 1 minute. So it's a slow bolus dose. So in this case, it would be 5.1. So we would then draw up 5.1 out of here, and it gets pushed over 1 minute. And then lastly, you have your infusion dose. So everything that's remaining in this would be your infusion now that the discard and the bolus are out. And this gets hung and ran over the pump over 1 hour. And it's programmable under critical care in the pump. After the infusion is done, so this runs over 1 hour, there's a 50 ml bag of normal saline that also gets hung just to get the rest of the drug out of the line. And there's a spot for the nurse to initial there that he or she has ran that 50 ml bag. Pretty straightforward, right? It's the whole thing behind TPA that people get nervous about isn't this part. It's the decision-making part beforehand. And you guys will be indirectly involved, but that decision will have been made before they come up to you guys in the ICU, which is the other reason that we really wanted you guys just want to look at this, which is the other reason that we wanted this machine in the CAT scan waiting areas, because I don't want patients coming up to the ICU unnecessarily. Then they get up there and we decide they're not getting TPA. What do they need to be there for any more than anyway? So that's kind of the gist with the TPA. I just want to see if I'm missing anything else. I'm going to send this to you guys. This is kind of all the steps that I just went through. So I'll send you guys a copy of this in your email, just in case you ever want to refer to it or read it over on your own. It really goes through all of those steps. Oh, I'm going to go through it with you because I already realized I missed something. Nothing can be mixed with TPA in one line, so the nurse always needs to get that second line on the patient. So we need 2 IV lines. Accurate weight, as I mentioned, there is no consent for TPA. We just need to document that we had that risk versus benefits conversation. That's the other reason that printing the telestroke note is important, because that telestroke note has that conversation. That's our record that we've had that conversation with the patient. So that would be that. I just talked about the actual mixing of it. It dissolves very easily. You don't have to shake it. You'll see once the sterile water goes in, you can give it a little gentle swirl, but it dissolves very, very easily. Then we pull out that discard, as I mentioned, and that bolus we administer. And then the infusion gets hung, and then afterwards that 50 ml bag. And then, of course, you are all familiar with the actual care of a patient who has received TPA. That process isn't different from a patient coming in the emergency room who goes up to ICU who had already gotten TPA. So we're really looking for signs and symptoms of neurological deterioration, right? Is that patient more somnolent? Are they having any bleeding events? Anything like that, we can stop the TPA. What I tell the emergency room is, if there's any doubt, stop that TPA and go repeat a head CT real quick. Like if you're concerned about their neurological status, you're concerned that they might be bleeding, we can stop the TPA. They can repeat that head CT and come back and we can resume that TPA. So never feel like it's a make or break scenario. Some of this is for the nurses, like the staff nurses. And then, of course, after or during the TPA infusion, we want to make sure we're not doing anything invasive on them. No NG tube insertions, no, ABGs unless they're really, really needed. But we don't want to be doing any extra poking and prodding at these patients. We did have a patient that we put an NG tube in the emergency room 1 year, a bunch of years ago now. That had a bleeding event just from the irritation of it going down. These patients can bleed very easily. The TPA half-life is rather short. It's really, I think it's like 23 minutes, don't quote me on that, but it's in that range. But the effects of breaking down that fibrin sheath are up to 24 hours. So they are at a risk for bleeding for a longer period of time. Anything invasive that we need to do, definitely wait at least 2 hours before we do it, but we want to avoid anything. I'm not talking about inserting an IV. That would be a compressible thing. I'm talking about Foley catheters and different things like that. Any questions so far? Okay, I'll send this to you in your email. Just wanted to see if I got like 2 more things to cover with you. I just wanted to talk about the blood pressure parameters. You guys are already somewhat responsible for this when a patient, again, comes in through the emergency room. But there's really 3 areas of criteria for what we're thinking about with our patients, with our ischemic stroke patients when it refers to the blood pressure parameters. So generally speaking, if a patient wasn't getting TPA and they have an acute ischemic stroke and they're in the ICU for whatever reason, we would leave their systolic blood pressure up to 220 in the first few hours. We want to gradually lower that. That would be the permissive hypertension range. So when you're thinking about a patient, again, whose blood pressure is greater than 220 and we're dropping that BP by 15%, you're still only expecting that patient's blood pressure to be in the 180s, 170s in those first few hours. So just keep that in mind that, we're not aiming for a normal tension in the first 24 hours. But this is really where we're focusing right now on our TPA patients. So again, before we give the TPA, we want the blood pressure to be a little bit lower than 185 over 110. Not bottoming them out, but we need it below 185 over 110 because studies have shown that when we give TPA and their blood pressure is greater than 185 over 110, their risk of bleeding is higher. That's the reason. So we're going to lower it a little bit. Our drugs are the same drugs that we've been using, nicardipine and labetalol. Don't get too happy with the labetalol. If it's not working, go straight to the Cardine drip. It's better, it's easier, we can titrate it, we can stop it. Avoid excessive lowering, of course. And then while the TPA infusion is going, and post-TPA infusion, we want to keep that blood pressure less than 180 over 105. A little bit different, but just the target there. And again, if it's in the 170s, we're happy with that. Leave it, don't touch it. This is just some of the other side effects. Of course, I was talking about neurological deterioration, bleeding, all the things that we're looking for. One other thing that we sometimes see with TPA is angioedema, especially if the patient was taking ACE inhibitors. This is something that we see semi-often, not super often. Basically, what we do is the sensitivity kit that we do for all medications. I would still stop the TPA if you're seeing the angioedema, just to make sure there's no airway obstruction, etc. Give the sensitivity kit, reassess. We could restart the TPA if we need to, but just something that we see sometimes. The NIH cards are up in your unit, in your stroke binder, if you ever need them when you're doing the assessments with the patient. They're also going to be on this, they don't fit in the back here. So we have a larger version of this machine in the emergency room, and the back pocket is bigger, so I have everything back there, but this one's a little smaller, so I'm going to poke holes in this and have them hanging. There's also going to be like a quick to-do card, what am I trying to think of? Like a card, just a reminder of how to go through the process if you guys need to activate the machine, etc. I also made, just in case you guys ever forget your Stroke Respond login, I made a generic login so that we can always get in there. I don't want that to delay anything for anybody ever, so that will be posted on here as well. I think that's all I have for the TPA part. Any questions again? No? Okay, one last thing, and then I'm done with you. I just wanted to talk about, because I don't often get to do education with you guys, I just wanted to talk about hemorrhagic strokes very quickly, or again, in the event that we have a bleed with our hemorrhagic stroke patients. The biggest things that we're thinking about with our hemorrhagic stroke patients is that blood pressure management. Very different than our ischemic stroke patients, right? We want to drop that blood pressure pretty rapidly in those first couple hours. So these are general guidelines by the American Heart Association. If a patient is coming in with a blood pressure, a systolic blood pressure of 150 to 220, our goal should be around 140 in that first hour. So we want to get it down pretty quickly. And if they're coming in with a systolic blood pressure greater than 220, then we want it closer to 160 in that first hour, 140 in the hours to follow. If in the event that they're coming in through the emergency room, hopefully they've already initiated this, but if we have an acute hemorrhagic stroke in the hospital, then you guys would be managing this part. And then the other piece that I always want you to be thinking about kind of at the same time is, why are they bleeding? And if they're on anticoagulation, do we want to reverse that anticoagulation? What I have found is that that's our biggest delay area in the hospital, is we don't always think about it right away. We don't always get the Andexxa on board right away. So the Andexxa is the reversal for Eliquis and Xarelto. So especially if it's a detrimental bleed, we're going to be giving Andexxa. If it's a questionable bleed, we need to ask hematology if they want us to give it or not. They're usually on board with this as well. So I just wanted to mention those types of things for you. And then, of course, monitoring for expansion. When is their next head CT? Is it already ordered? Let's not wait for a neurological decline. Let's get that head CT and determine whether or not it's stable before it happens. So that's kind of just the brief reminders.